Morning, Bill.
Good morning.
Hi, this is Dr. Medor. I'm just going to go back to being muted here. Just wanted to let you know I'm on.
Okay, you're on 3029?
Yes.
Okay, thank you.
I'm still baffled by why that didn't come through. And it didn't even not come back to you, right?
You know what? I had about 50 emails come back to me on Friday.
Hey, good morning, team. Just before things get started, wanted to say hi and let you all know that I'm indisposed today.
Indisposed.
All right.
Thanks for your service.
Good morning. I have two new phone numbers that I don't recognize. 3029. Who is on that phone? Last four digits, 3029.
That's Dr. Medor.
Okay. And then I have 6562.
That's me, Will Greenhut.
And then I have 3227.
Hi, Hi, that's me, Dennis Mel, 3227.
Yes. Thank you,
Thank you.
Dr. Okay. Good morning, everyone. Give us a couple of minutes here. We're trying to get in touch with Dr. Murphy. Dr. Murphy will be with us in a few seconds.
Good morning, everybody. I'm so sorry about how late I am getting on here and then to finally get it to boot up. Does everyone hear me? Okay.
Yes.
Good morning. So sorry about the last minute change. Initially, it was going to be an in-person meeting, which I didn't even realize. I thought it was still Zoom. So when we realized so many people were still in the Zoom mode, we switched it back just to do Zoom today. And then at the end of the meeting, we can talk about how to go forward. But, you know, when Karen had contacted me, she had very few RSVPs for the in-person meeting. So we also need to think about what do we do going forward, because we want to maximize the amount of people that participate in the meeting, as you can imagine, and everyone's word is important. Everyone's input is important on all these factors. So think about that, dwell about that, and we'll come back to it, because I want to have some kind of, you know, collaboration on how we want to do this going forward in the in-person versus virtual meetings. So Karen, do you want to do a roll call? Or Bill?
Okay. Dr. Murphy,
Yes.
Dr. Papish,
Here.
Dr. Arshak,
He's there, I saw him.
he was here earlier. Okay, so we'll wait a few minutes. Dr. Stu Miller,
Yes, here, good morning.
Dr. Brutus, Dr. D. Cussard, Dr. Mao,
Here, present.
Dr. Chung,
Here.
Dr. Midori,
Here.
Dr. Templeton, Dr. Greenhut,
Green Hut present.
Dr. May,
Here.
Dr. D. Thomas, Dr. Cohen,
Good morning.
Dr. Santos, Dr. Kakuza, Dr. Larson, Dr. Quintero.
Here.
Okay, and in the office, we have myself, Karen, Jeff, and Dave Violante.
Okay, thank you, everybody. So with the packet was sent out the minutes from the last meeting. Just want to know from the June 7th meeting, if anyone has any corrections, additions, anything they want to add. Otherwise, I'll ask for a motion to approve the minutes.
Motion to approve, Dennis.
Thank you. Could I have a second?
Second, May.
Thank you very much. So going on to old business, I don't have anything to add about supraglottic pilot program unless, David, you have something to add. I've heard nothing back. I did put out another inquiry, so I'm not sure why this hasn't been moved forward from the commissioner's desk, other than, you know, I mean, with the whole Cuomo thing, maybe that was an issue. I don't know, but certainly I've heard nothing back. The completed program is sitting waiting for his approval. And we've had more inquiries from upstate areas that really want to be part of it. So it's really growing, you know, how many participants want to be involved in the project. So hopefully we can move it forward. But we do have a lot more going with the SLAMS project. Mike, you want to talk about it?
Certainly, thank you. Good morning. So the protocol committee's met a few times. We've collaborated with Westchester County as well on the project. A revised copy was sent out this morning to the group. Of significance, essentially, is that we bolded the word exclusions And in fact, maybe I can share my screen here.
Yeah, try to share it with us, and then, because it's not long, everybody could look at it quick.
Okay, so can you see it now?
Yes.
Okay, so what we did is we bolded the word exclusion at the beginning and at the end. And so as a result, also the time frame was written incorrectly in the previous versions. So now it's an exclusion if the transport time to a New York State designated thrombectomy or a comprehensive stroke center is greater than 30 minutes. And then a new sentence added, if any of the exclusions are met, the patient should be transported to a primary stroke center or an appropriate ED. And so no changes to other pieces here. And then just the SLAM stroke scale as well. So those were the significant changes that were made on the first page. So the plan is to get the revised version out today, and approved today. I'm trying to think. I think Dr. Papish, wasn't there one other small wording change?
Wasn't it something about bed bound?
Well, we had a discussion about wheelchair bound versus bed bound because
Yeah,
New
that was the one thing.
And then I believe Frank suggested just putting in the last known well time instead of the verbiage we had there to reflect the fact that that's the verbiage we use.
Right. Thank you. Yeah. Thanks for that. And so what the plan is from here is that the group is going to develop a video training program, something fairly quick. They're hoping 10 to 15 minutes, and then do an online quiz, which will be accessible from the region's websites, both the Hudson Valley and Westchester region. And we expect that once the training program is rolled out, that we need about 3 to 4 months of training time to make sure that we get all of the providers, because it needs to be BLS and ALS. So that's where we currently stand. And so we need to get these revisions approved so that we can then move it to the training group and they can roll out the training.
So do you want to make an official motion, or Dr. Papish, do you want to make an official motion so that people, unless people didn't have enough chance to look at it? I mean, they were small changes this morning. This is the same. We put out in April and May. We really started this, I think, in April, right, Mike?
Yes, the first one came out. The first one came out in April, and there's really no substance changes. These are just clarifications on the uses of words, and the only exception was in 4F. We had that the transport time was a less than 30 minutes, and it should have been a greater than 30 minutes.
Didn't we already vote on it? I guess not.
We did, but we just need to adopt the changes.
Okay. So I'd like to make an official motion to adopt the changes aforementioned. Second.
I'll
Dennis,
second that. And anyone who's does not want to approve, speak up. Otherwise, we'll assume that every voting member is in favor of. So any dissensions, any concerns, any issues? Dr. Mordori, you're on mute if you're trying to talk to us.
Yes, I said I have a continued concern that this actually doesn't improve care, but I think that that's been clearly outweighed. Yeah, I think that I see the patients that get sent on for thrombectomy, and I see how many of those actually get endovascular care, and there's a big discrepancy still between that. So I'm still not convinced with this long time frame that actually improves outcomes. I think a much shorter time frame may improve outcomes, but I'm still not convinced that this does. But I certainly understand that the field is moving in that direction. However, despite that reluctance on my part personally.
I think though, I had such a dramatic case of it, and that's the one thing, Dr. Midori, that changed my mind, because I agree with you. I used to actually was not in favor of TPA at all with strokes, to be honest with you. You know, like 10 years ago, I was like, what? And I really felt like I was wondering if really we made a difference, or was the person getting better anyways because it was a reversible event. However, I had a patient come in who, you know, walked in with her husband, had symptoms, and then collapsed in the bathroom. Well, of course, a nurse let her get up to go to the bathroom, which is always my favorite with a potential stroke patient. And she literally had a huge clot in her brain. And she was so out of it that the neurologist said, you know, this is a moot point. This is not going to happen. And I called the endovascular surgeon at Westchester and Center, and she came back to work as an attending pathologist in the lab. Yeah. So this was really one that, you know, was dramatic for me.
Yeah, I completely agree with you. I am on board with TPA. I'm on board with endovascular care, absolutely. And I've seen great outcomes. And I think there's really good and strong evidence. The very low stroke scale here, however, means that we're sending a lot of patients on who are clearly not candidates for endovascular intervention. They won't get it because their stroke scale is so low. And also the time frame, if it's already, you know, if it's 22 hours, 23 hours, the likelihood of actually improving, unless you have a large vessel occlusion, and these patients are not going to have any evaluation beyond their you know, a basic score. They're not going to have CAT scans, they're not going to have CTAs, they're not going to have any perfusion studies, nothing before they get to, until they bypass a primary stroke center and go to a comprehensive stroke center. But most of these, not many of these patients, most of these patients will not be good candidates for endovascular. They may be good candidates for stroke. Most will be out of the TPA window at that point. So it's, and they may arguably get different or maybe even better care at a comprehensive stroke center. I just don't think most of them, the vast majority of these patients who bypass primary stroke centers, are not going to have an intervention. And if that's the reason for sending them on, I think we should understand that that's not going to happen. What we're doing is saying we're going to send all of those who are potential candidates there and let them decide which ones actually get intervention, rather than actually kind of taking a look at that before, discussing it with someone who does these procedures, deciding that this is a poor candidate, and then deciding not to take them out of their local community. But we're going to bypass, and we're going to take a lot of patients out of their local communities for no intervention. That's my concern. I'm on board with TPA. I'm on board with endovascular care. I just think it would be better to have defined a better patient population in order to bypass local communities to go to comprehensive centers.
I don't think that's a bad point, to be honest with you. I think that because of where we're located, we're going to be seeing them and then decide. And we use, I don't know if you guys know, at Garnet, we use the Westchester Neurotelehealth. So we do discuss these cases and decide who should go, who shouldn't, who would benefit, and who is it worthwhile to do. Yeah. So I agree with you that it's not, your point is well taken, in my humble opinion. Any other comments?
Dr. Midori, I certainly understand your point as well. And I think that as we talked about this in the protocol group as well, I think this time frame initially started of a transport time of greater than 60 minutes, and we've reduced it down to 30. So when you do look at a circle or radius around a comprehensive stroke center, the patient really needs to be within 30 minutes of that. So I don't know how many primary stroke centers really are going to be bypassed. And again, I also appreciate all of your comments, but I don't know that this is, from an EMS perspective, that this is really going to have a profound change, at least initially, because anybody who's more than 30 minutes is going to a primary anyway.
Yeah, I think that's an excellent point, and you may be a moot point. So I guess time will tell. And I know we've had, as have all of the people on this call enormous difficulties with getting transport for transfers. So maybe this makes that easier. Maybe it makes it more difficult. Maybe it has no impact. I'm not sure, but I think it's worth looking at that down the road to see what impact this may have. But it may not actually have the degree of impact that it seems to have the potential to have on the local communities, on the EMS community. We'll see.
Certainly, and and along with Dr. Murphy, I recall these discussions back when when we first had STEMI centers and these similar kind of conversations. I think one of the things that we do have going for us this time around is the electronic data reporting, and certainly I don't know that we haven't talked much about that, but this is probably something that needs to be very carefully monitored at the regional level by both regions to see what patients are being sent to comprehensive stroke centers and if it is making a difference. So I appreciate your comments.
So Bill, could we have this be one of our QA projects going forward next year so that we look at each one of these cases and see what's the number that does get interventions? What's the number that, so we can reevaluate this whole system, say for the next 6 months, so that we really see, does it make a difference? Is there an impact? And what are the consequences?
Oh, we monitor stroke data now. So yeah, that's not really problematic to take care of.
The problem side with that is who got the intervention and who didn't, because we don't get the feedback from the hospital to know that.
We send most of ours to Westchester, and they actually do a great job at providing feedback. They have someone who follows each one of those cases. I assume the same would be true at any comprehensive stroke center or any thrombectomy capable center. And if not, I think that it's worthwhile reaching out to those places to make sure that they have that potential to provide feedback, because I think that it's enormously important. And if it has a great outcome, great. And if these criteria can be narrowed or broadened, but more likely narrowed, in order to pick out what's the more specific patient population that really is going to benefit, maybe we end up lowering the denominator and with the same outcomes for those people with intervention, so vastly increasing the effectiveness of bypassing local, primary stroke centers. I think that would be incredibly interesting.
I think it's a very valid point. Do you guys feel comfortable with launching this off? Or how do you feel? What's the consensus here?
Well, we need the education piece, right?
Yeah, well, we have to do a bunch of things. Yeah, it's not gonna happen automatically, that's for sure. But I didn't want to move anything forward, Mark, without people's, collaboration and really feeling like it's something we can do, because it is going to be an effort to get everything else done, both the education, the rollout and such. So I don't want to move forward unless we're good with what we have so far. So anyone in direct opposing this motion forward, or there's a chat, let me see. If we move it forward, does anyone have any reservation about doing so? Forever now, speak, please. Okay, that silence I'll take as a verbal and acquisition of, we'll move this forward. And so, Mike, the next process here then is to look at working out a training ability, doing it. I think the best way would be, again, either a video or one of the things we did before when we rolled out changes in our collaboration protocol, and just move forward with that. And we can work that through the protocol committee if you're okay with that.
Yeah, absolutely. In fact, Dr. Berkowitz is stepping up to the plate quite a bit too and wants to pull together the program. So we will move this document actually forward to Westchester, let them get their final changes approved, and then we'll get the training in place and talk about QI.
Okay, great.
Thank you.
This is Frank Quintero. We're actually meeting next Monday on our REMAG committee. And so I'll bring this to the group, and on the next protocol meeting, we can discuss further. And I'm going to excuse myself from the rest of the meeting. I have another meeting at 10 o'clock. You know, once the minutes come out, I'll catch up with anything else that I missed.
All right, thanks, Frank.
Thank you.
Next is service upgrades. Karen, I have no upgrades that I know of.
Okay, I have a few that we have to do. What I'll do is just read them, and then if there's any objection, we can discuss them. If there's no objections, then we can just pass them, and then we'll send it up to the state saying that they were approved. So the following agencies have requested adjuncts. So I'll give you the agency, the adjunct, and the date they submitted it. New York Power Authority requested a PAD adjunct on June 7th, 2021. Now, what we do with these is we approve them pending the REMAC's final approval. So we say that they can use them temporarily until the REMAC approves them. Right? So that's a PAD application. Mammocating First Aid Squad requested to use 12 lead and CPAP, and they did that on August 9th, 2021. Monroe PD requested to use Narcan, and they did that 8/10/2021. Amazon Services requested a PAD authorization, and they did that on 8/20/21.
Is that their warehouse or thing? Amazon, when you say Amazon?
Amazon Services, I believe it is their warehouse.
I think it's like, I don't know where it's at. It's right around here somewhere.
It's in Orange County somewhere, and I can't remember where. I think it's right down the street,
Yeah,
actually.
that might be Stewart.
American Legion Ambulance is requesting CPAP. They did that 8/23/2021. And Port Jervis VAC is requesting CPAP and 12 lead EKG transmitting. They don't interpret the 12 lead as a BLS service. They only transmit it. They take it and transmit it, but they have the equipment to do that. They requested that on 8/23/2021 also. So we have six adjuncts to approve.
Well, it's really, what we do is we actually don't have to vote on it. It's more so we're making sure that their applications are in order, and then we just send them along because it's really the state that does those. However,
Excuse me, Pam, the REMAC has to approve them because the state doesn't put them into the adjunct bucket of the BLS agency until we at the REMAC approve them. That's
I didn't think it required a vote. I thought it was more that they had their ability to do so. They had the equipment, the medical director was on board, and we rubber stamp it.
well, we might rubber stamp it, but we have to approve it. The REMAC has to give their authority to use it because these agencies do run under the REMAC and under the medical directors.
Okay, so do you want to do a roll call vote?
No, we don't need it. We can do the same type of vote. If anybody has an objection, let us know and we can discuss it, or if anybody feels that we need to.
Okay, so on a motion to approve these adjuncts to be approved for each one of the organizations he just read off, if anybody has any concerns or questions, please speak up. Otherwise, we will approve them and move forward unless anybody has any concerns. Dr. Larson is on now, Bill, for your attendance.
Yes.
Any comments or concerns, or we'll move forward? Okay, evaluation subcommittee report. Did Dr. Ashard join?
He was in before and then said, I believe that he was not going to be available.
Okay. I have not seen any, I saw one case come across just recently, but I haven't seen anything else from the evaluation committee. Did you have anything, Michael?
I do not.
Okay, so there was one from Woodbury that's in preliminary stages, I know of. So we'll report it out next time, because I don't even know if he's done any background information on it. But it was pushed forward. And Bill, do you have the DOH enforcement notifications?
Yes, I do. And I have actually two of them that are in our region. And the first one was certification. It's been suspended for 6 months on James Schofield. Effective 6/9/21, the suspension is stayed, placed on probation for 3 years, effective 6/9/21, and is required to take an ACLS refresher class. The second one is also an agency from us. It was Mountaindale Fire First Aid Squad. They were assessed a civil penalty of $2,000, suspended for 1 year, effective 6/14/21. The suspension is stayed for violation of Public Health Law 30, Article 30, Section 3012B, 3006, and Part 821. It's agency code 5221. The next one is Richard Harold Jr., assessed penalty of $2,000, $1,000 stayed, placed on probation for 3 years, effective 6/10/21, for violations of Part 803. The next one is the Nassau County Police Department issued a formal reprimand effective 6/14/2021, assessed a civil penalty of $2,000 for violations of Public Health Law, Article 30, Section 3006 A and C, 3053, and Part 821. The next one is Bensonhurst Ambulance Service, suspended for 1 year, effective 6/10/21, for failure to comply with previous stipulations and orders. That's agency code 7193. The next one is Will Davies, was issued a reprimand on 9/2/21, placed on probation for 3 years, effective 9/2/21. Assessed a civil penalty of $2,000. Half is suspended pending no further violations for violations of Part 800, Section 3. The next one is Kevin Seaver. Surrendered effective 8/24/21 for violations of Part 800, 16A and 16A11. That's the last of them.
All right, thank you. So moving on, helicopter committee report, Dr. Larson and Dr. Stu Miller.
Good morning. We had a meeting earlier this morning. There was no new business. The old business of the legislation authorizing air ambulances to store and administer blood products is yet to be signed by the governor. Governor Cuomo did not, and Governor Hochul has yet to. Understand there's some turnover of administrative staff with the new governor, and so will likely be some time before the new health staff will pick up on this issue. And so other than that, there's been no incident reports. There's been no communications issues. And so we had a quick meeting.
And what about in terms of utilization? Is it still like the same number? Are you finding higher numbers with our problems with, transportation and for, on the ground, we're running into issues trying to get people, out of our institutions to a higher level of care and to other. Have you seen an uptick, or is it still the same amount?
This was a busier summer, but we didn't do it like a year over year comparison. It felt like a busier summer, but we will gather those data and then compare, and should be able to then compare year over year to see if it has gone up in volume or not.
You
And
know,
we can
just,
separate that by region and by county.
and Dr. Larson, did you want to add anything or?
No, I actually missed the helicopter meeting. I just myself just returned from Louisiana, where I've been on deployment for Hurricane Ida. Just a quick note is that interestingly enough, AMR under a FEMA contract provided actually 40 aircraft into the field for possible use in Hurricane Ida. We actually used none of them, but they did provide 6 helicopters and I think about 34 fixed wing aircraft, which I thought was pretty interesting given sort of the general situation going on in the country, that they were able to come up with those resources. Fortunately, we never had to use them. We didn't do any kind of mass air evacuation as in Katrina. But anyway, just an interesting point in terms of the use of aircraft across the country. They must have had a number, and that included crews. Their obligation is to bring in crews. So
That's a pretty impressive number. I mean, my Lord,
yeah.
40?
Yeah, I mean, like I said, 6 were helicopters and the rest were fixed wing assets that they were able to bring to the field. In fact, you know, the military, you know, we were in discussions with the military about mass evacuation, and actually this time the plan is that we would do the critical patients through the AMR assets and the less critical patients through DoD assets on the large craft, you know, on their large, you know, 130s and C-17s and stuff like that. Luckily, none of that came to play. It is a, well, while I'm on it, you know, look, it's just a still devastated area. There's large numbers of, there's something like 40 to 60 nursing homes still don't have their, power, or are missing, you know, significant parts of their roofs, have leakage, damage, that kind of stuff. There's a number of hospitals that mostly in more rural areas. In fact, our DMAT teams were doing ED decompression missions in various places in southwestern Louisiana. But actually, we're basically pulling out all the NDMS assets, and we'll probably be completely out of the field by around the 20th of September. So things are somewhat coming back to normal, but certainly large numbers. There's still 200,000 people don't have power, and significant challenges to you know, the infrastructures of these hospitals and nursing homes, because they've been running on generators. And, you know, most of these generators, they're good for, you know, 5 days or something like that. But when they're running continuously. So there's all those issues, things challenged. And while I'm on, I will make a pitch to any doctors, paramedics, nurses who, you know, we're in desperate need of folks, and supposedly NDMS is going to start opening up some hiring. You know, it's a very tortuous process to get on to the DMAT teams or into NDMS. But anyway, I encourage you to look at USA Jobs and you know, and join us, because we're in need. We're of course being challenged by COVID. We also were running the repatriation mission from the Afghanistan. And so there's a number of things that have challenged the system, and our teams are pretty limited. So anyway, if you've got plenty of spare time and you're interested in going out into sometimes not very optimal conditions, austere conditions, we certainly appreciate folks joining the system. Anyway, a little bit of deviation there from the helicopter report, but I thought I'd throw it all in at once.
No, I think all that is so important, because I think, you know, we need to know what's going on around the country, and you were there firsthand, because you don't always get these reports. I didn't know that many people still were without power. That's impressive numbers. It's just devastating, actually. All right. Dr. Larson, I keep with you for the RTAC. There was an RTAC this past month, right? Maybe
No,
not?
I don't believe so.
Okay.
I don't
Maybe
believe
I-
so. There
Maybe it was stacked. I saw something, but
there
I
was a
didn't-
plan, but I've never seen a finalized meeting unless someone else knows better. I don't.
I'm not aware of it.
Okay.
What they did say is there will be a meeting after the stack meeting. So the Hudson Valley will meet after stack, but there is.
That's probably what I saw. Sorry, I didn't mean to scare you there.
There was a little bit of an update with the RTAC. The RTAC has created 2 new committees that involve EMS. One is EMS and transporting, and the second one is blood transportation. So the first one met on about EMS, and they there was a little miscommunications with some of it, but basically they talked about the use of tourniquets, or the not the use of it, or the poor use of it. And then the second topic that we started talking about was cervical collars, about when to use them, when not to. And the third one was intubations. And we talked a little bit about intubations. We talked a little bit about supraglottic airways, and we also talked about RSI intubations. So nothing has come out of that, but those are the 3 topics that are going to be main topics with that group. The second group is the blood group. They're meeting on 9/21/21. I think it's a 1 o'clock meeting. If anybody is interested or wants to join that, they should contact Westchester Medical. I can give you the contact information of who is organizing all of those meetings. But we haven't started anything with that yet, so I don't know what the blood meeting is going to be about. But I think it's going to be about blood in the field, both at the helicopter level and at the ground level. There was a lot of discussion on what it takes now just to transport with blood, so it'll be moving on from there.
Okay, thanks. So Jeff, you're up with quality improvements.
Hey, in early June, New York State released an updated schematron, which included a new facilities list, which has 11,000 and change facilities. The schematron change did, of course, result in issues with agencies being unable to close their charts. And since then, we have done 2 more schematron changes with somewhat better results, but we are still working with the vendors, in particular Zoll, to get the back charts, because we have 2 agencies that can't transmit their charts because if they transmit them, they can't close them for billing. It's a pretty significant issue, and we are working on that. We've been having regular meetings with the state informatics people as well as the vendors to fix that issue, along with some other rule issues that have popped up for ALS first response agencies. And work is ongoing to fix all those. It does, however, take time. And it seems that every time we fix one issue, 2 more pop up. It's a work in progress, and we are finally seeing light at the end of the tunnel, which is not an oncoming locomotive.
Jeff,
Yes.
Can you talk a little bit about the hospital hub that's coming up?
Yes. New York State does have a hospital hub that is available. It was made available through the Coverdale grant of, I think, 3 years ago. For those facilities that do not, are not participating in that, New York State has provided access to our regional bridge with an elite viewer, which means that if a hospital is receiving a patient from Mobile Life, that hospital can actually get all of the information. They can see that PCR. They can't obviously see charts for patients that they have not received. The idea behind that is to finally eliminate faxing. because faxing just, it doesn't work and it should not be used to transmit any data that involves HIPAA. I know that Dave Jensen has been working with Zoll for a hospital hub, and perhaps he could speak a little bit to that.
Thanks, Jeff. This is Dave Jensen, everybody, with Nuvance Health Systems, Zoll Care Exchange. We have enrolled 7 agencies currently. We're receiving about 40% of our charts through the Zoll Care Exchange. It electronically comes into us. It electronically matches to the chart. There's no needed further needs by myself or anybody here in HIM to load the chart into the Cerner chart. And it is an excellent program for us to give feedback back to the agencies and to the providers. They can actually log in through EMS charts and see feedback from the hospital in real time at discharge. It takes about 20 minutes to go back to the provider. And we hope that more agencies will come on board with this platform. And we're looking to have a universal product across the region so that all the hospital systems can access it. There is a financial requirement of the hospitals, but not of the EMS systems if they are Zoll or EMS charts. Unfortunately, the other vendors do charge a fee for their product to be able to cross over to to EMS charts and Zoll. Any other questions?
Okay, thank you. So I think that one of the things, we're moving forward onto the protocol committee, and one of the things, that I think we have to tackle at some point is all these issues with transportation and such. And so maybe we can take that up under new business. What is the solution? I don't have one, but trying to work on things. Michael, protocol committee.
Thank you. And a special thanks really to Dr. Larson and Dr. Arshad. I don't see Dr. Arshad any longer, but certainly we do enjoy hearing your reports as well as you going into the disaster areas with the part of the DMAT. It's been a significant part of what you do, and we are most appreciative of that. So thank you. Some of my stuff has already been reported on. There is an ALS upgrade tag that has ongoing meetings to look at the ALS upgrade process. Bill, do you have anything that you want to report on that topic today?
That was what you said you were going to test, sure.
Hey folks, this is David. I'm chairing that particular tag, and I am magically behind the camera on your computers, just out in the ethers here of the office. So that's why you can't see me. Our committee has met quite a number of times. Probably we started off every week and then every other week to look at the ALS upgrade process from BLS to ALS, from BLS to AEMT, from AEMT to paramedic, and then from agencies with some kind of an ALS ability from out of the region into the region. And we did a number of things. The first was to look through our current process and reference public health law and cite it for every component of what we do to be sure that we are actually doing it under authority, and we are. We put that into our current document for anybody who's interested in seeing that. Just let us know and we can email it out to you. The next step is to finalize the regional procedure and then sort of present it to other regions so that we can go to the state in a concerted effort. And so the changes that we are proposing to the current document are as follows. One, to separate our current packet into an application and agreement section, which is just a few pages long, and then a system analysis guidance tool, which would be optional. This tool would be filled out by agencies to help the REMAC physicians understand what their input into the system would be and why it would be a good idea to have them as ALS providers in the Hudson Valley. And it'll provide a tool for them also to say, holy cow, there's a lot of stuff here that we have to think about, and to provide that information. That's part one. Part two would be that AEMT and paramedic must be 24/7 to the highest level provided, and then have a two-tiered response if they're not a paramedic system. That's in our current system, but we want to bring that forward to make sure that that was something the REMAC wanted to continue. That's part two. Part three is to remove the public meeting component and create an agenda item at the REMAC for anybody to comment in. This would take away some of the CON-ish issues that the state had with our current process, and still continue to provide a public comment for anybody so interested. And as a part of that, we would remove any of the fees associated with the public meeting components. And so by doing all of those pieces there, it should be a little bit more streamlined, efficient, and easier, still provide public comment, still provide 24/7 coverage. And we believe that that's a good way forward. So to that end, I'd like to ask for any other comments about what we need to do. The final step is to actually just take this, if the REMAC agrees on it, and come up with a formal document. We have a number of folks that are interested in doing that, which we can do, then bring it to the other regions, which will then, as a final step, go up to the state as a group for hopefully the next CMAC, which should be October 19th and 20th.
And if I'm not mistaken, David, the Remo region had issues with this too, so they were very interested, correct?
That's absolutely correct.
Yeah.
The one thing that the entire committee really wanted to stress and have the REMAC stress to all of the medical directors was that it would be extremely helpful, just tremendously helpful for the entire system if all of the BLS agencies did all of the BLS adjuncts. That would reduce some of the stress on the ALS system component side of things, and also, improve some patient care side for folks going to the hospitals, especially when, ALS may not be available. At the very least, they could do those BLS adjuncts and continue and upgrade their care going in, and they're certainly able to do those things.
Well, the nice thing today was certainly Bill announced some agencies that are upgrading certain things. One in my area, Mammocating. My God, I was their medical director back in 1992 when I started, and they had nothing. Mammocating First Aid Squad. I'm like shocked that they're going to CPAP and be able to. That's a great addition, especially where they're located. So you're right. These are the things that we have to propagate. These are the things that we have to encourage. And, in my humble opinion, I think many would be interested in this because it's something new. It's another adjunct you can really help a patient with, but it encompasses the medical director to oversee, educate, and monitor that these things are going on. And, as we all know, there's some of these BLS agencies just never see their medical director. So it's definitely a work in motion that hopefully we can push forward and get more interest in.
So Pam, I know that the next REMAC is going to be after the CMAC SUMSCO. Perhaps it's possible to get a provisional approval based on your and Mark's approval of this. Once this final process gets out, we're hoping to have something in the next week or so.
Yeah, so the next CMAC is October 19th and 20th is the next meeting. We haven't had one since before the summer. So I like it. I like how we changed, the public hearing part of it. I like that we still are retaining, the standard that we feel that 24/7 is something you need to provide. It's not a go lightly kind of process. We need people to make a commitment and to fulfill that commitment for the constituents and their local constabulatories. And I think that, these are all important factors so that we don't dilute a system, but we keep an aggressive system out there that is able to help the community. So I like the changes. I like what the tag committee, or I don't know if you called it a tag or the committee suggested. I think those are all good.
If there's
Great,
any,
thank you.
Are there any comments from others on the group? And do we need to have a vote to move this forward, or is it something that we'll just do? Because this ends up coming, REMAC has the authority through public health law. It's probably something that we need to vote on, Bill, or no? I'm not sure.
I'm not sure either. I think we should. Vote on it, so everybody has.
I think because it's an actionable item that we do, we should vote on it. It's not like the upgrades that we're just rubber stamping and passing along, because we're not. But I think this is a real actionable item, because this is something that we do and we enforce, and something that we expect to occur at our level. So I think this is something we should do a roll call vote on, or if anybody just wants to indicate any opposition, that's fine too. However you want to do it. If you want to do roll call, Bill, that's fine.
I don't think it requires roll call voting. So we could just do an opposition vote.
So with what David was recommending from the committee for changes to our upgrade process, does anyone have any issues, concerns, anything they want to change, anything they want to discuss further at this time? Okay, with that silence, I'm going to take it that there's no opposition. So we can go past anything else, Mike, from protocol, or that was good?
No, I do have a few more items.
Okay, go ahead. Sorry.
That's okay. I'm glad we got that done and out of the way. That's great. Thanks for your report, Dave. Thanks for the comments. The RSI program is also being evaluated and updated. That work is in progress. Also brought up at the last meeting are issues that the region is having with credentials, credentialing policies and procedures. Certainly, I think it's a great discussion for this body, but in summary, as I understand it, there are agencies that are not submitting certification cards. Some have not submitted them since 2020. There are 3 agencies in particular that have not done that. The region feels that they have some challenges enforcing that. Certainly, we've discussed at this level in the past the responsibility of the medical directors who agree to enforce the rules of the REMAC. And another topic that's all related to this is that the regional office even has providers or new people who are entering the system who are showing up to take the protocol exam without affiliation letters. So it appears that the region is having some challenges working with some agencies, and turn to the protocol committee, and certainly we are turning to this body for help and direction in being able to enforce the rules and regulations, policies and procedures of the region.
Yeah, so I think that I'm not sure how these events are occurring, like somebody to show up to take the protocol exam and they don't have an affiliation agreement. Is it just a lack of people understanding the process, the educational piece, or I'm not sure, Mike, where the breakdown is, but it is,
So
go ahead.
No, yeah. So Karen, maybe you could, because you've explained a few of these, like so when somebody calls in advance and you tell them at that point, and then I believe you even followed up, right, that they're supposed to have this credentialing or these affiliation letters.
Right. Some of the agencies aren't submitting the affiliation forms prior to them coming in. So when they show up, they think that the agency submitted the paperwork and the agency hasn't. So it takes us 20 minutes to find out, from the agency if, these people are employed and we need the affiliation form.
I think the other big thing too is to keep track of where people go. people change agencies and there is no update to the region. So we still think they're under one agency. And I know a couple of the names that were on that last list weren't even affiliated with those agencies anymore. So those become personal issues for each provider, for each, whatever level they're at. It's kind of like what we are responsible for in our hospitals. We need to make sure we have all of our CME and our credentials in order, and we have to submit those to the medical staff office, the credentialing office, and keep them updated. So, I know that the one difference with the pre-hospital population is the ability to recertify on a national level with the exam. And so it's out of sync with the dates for our local level. I think that becomes an issue. So some people let their cards or affiliations go, and yet by the time that it comes around to the next cycle, they're okay again. So it becomes kind of labor intensive of where people are and what are they doing. I think it has to go back to whoever at the agency is working on the credentialing and work with their medical directors to make it kind of more of a good communication and smooth process. But I don't have answers to that either.
And if I could, just for a minute.
Yeah.
Again, I don't know the particulars of what Karen's referencing, but I can tell you some of the difficulties that we have as an organization. Ever since the state went to the sign up to take your exam, we really have no idea when an individual is set to schedule and take their exam. And in their joy and accolades of getting that letter from the state when they take their exam, they immediately turn around and call the region and say, I need to take my MAC exam, because they know the process. And then, we've even had a couple of staff members where we said, you didn't tell us when you were taking the exam. Well, I wasn't sure if I was going to pass or not, and I didn't want to be embarrassed. Okay,
Oh.
so it becomes difficult. It's just maybe a little insight, and I could be way off on that. But again, back to your point of looking at agencies that are not credentialing it, somebody please correct me if I'm wrong, but if I understand the policies correctly, REMAC has the ability to remove said medical director. And that's really the only authority that exists. As a REMAC, you can disavow, I guess if there's a word you want to use, that agency's medical director for failure to follow the policy. But I don't think you can go after an individual or an individual agency. Somebody correct me if I'm misspeaking.
David, I think you're right.
As a result of that, we have been, at the office, we have started to notify the medical directors of the people that are deficient. So as some of the medical directors have seen that come through with them, so that they will be aware of where the deficiencies lie.
Again, I'm going to just be the bad guy in the room because that's what I do here. But I think at some point REMAC is going to have to take a line in the sand and make a decision. You're either going to hold an agency to the standards or you're not. And if you're not, then we're kind of spinning our wheels in the mud. So
Certainly, I think from all of the discussions that we have here and we have at the protocol committee is that I think we probably have drawn that line, Dave. I don't know of anybody who sits here and says that it's acceptable for an agency not to follow the policies and procedures. I think the challenge that we have is how do we do that? And what I think I just heard from Bill is that they've started to involve medical directors. And I'm assuming you're getting the results that you need, Bill?
Not necessarily yet. We just started doing that. So I'm not sure that some of the medical directors are aware what that means. And I think this will help, and maybe a statement from the REMAC saying, hey, you got to follow these, basically what Pam was saying before. I think that might help also.
So is there anybody on the call that doesn't feel that we shouldn't be enforcing the policies and procedures? And as Dr. Murphy says, speak up now or hold your peace. All right, so Bill, let's continue to monitor the situation. Let's continue to keep the medical directors engaged. And if you find that you're not getting results, then we'll bring it back to this group for discussion about that medical director's ability to perform his function or her function.
Is the list of medical directors thus far that you have contacted been factual and really are the medical directors, or is that list also defunct?
We believe they are the current medical directors of the agency. The agency is supposed to inform us if they change medical directors. But we do have some, mostly on the BLS side, agencies that have some issues with doing that. But we do follow up with them as soon as we find out that that medical director is not responsible for that agency. But on the ALS side, that's usually pretty good.
Okay.
All right, thank you. So the next thing that I have is just Dave Violante reported at the last protocol committee meeting that there's a lot of information and good work being done on quality assurance at the state level. Dave, I don't know if you want to take an opportunity to discuss that or just pass for now.
No, I'm chairing the Quality Metrics Committee at the state, which is one of the new committees at SEMSCO. And we've been meeting every other week or so to go over what actually quality means, how we can measure it using current technology, the state's involvement, agency involvement, regional involvement, and that sort of thing. It's an amazing and dynamic group that is very involved in this at the national level. And so I think we're making some really good progress forward. I think it will help Jeff in what he does at the region, and then all of the agencies involved throughout the region in not only understanding the system, what's happening in it at the regional level, but at their own agencies, how they can actually look at data. There's a new program that the state is going to be using to create an information dashboard. And so we'll be reporting at the next CMAC SEMSCO and then get that information out to folks here as well. But there's a lot of really cool things happening with this committee, which is great stuff.
Great, David. Thank you very much. And Dr. Murphy, that wraps up the protocol committee's report.
Okay.
Question was whether you.
Thank you, Mike. So that brings us to new business and open forum. Did anyone have any items? I have the one about how we should handle these meetings forward and just the discussion of transportation. Anybody have anything they want to start? Thing you want to bring up? So for the meetings going forward, we should have an idea. I know we were trying to do them in person, but I have to say, for me personally, doing them with Zoom is much more efficacious for me. I don't know how the rest of you feel, because it doesn't pull me out of here, out of the hospital. And so I can run the meeting and still be here in case stuff is going on. And that is, something helpful for me. I wasn't sure how people felt about this. We were going to go to in-person meetings here at the hospital, and then we, brought it back once the Delta variant and the numbers were climbing. So we've gone back to a small percentage of people that can meet, 25 to 50%. But I wasn't sure how you guys felt about this meeting going forward. Any comments?
Yeah, Pam, there's a executive order that says all of these types of meetings have to be open to the public, and they have to be public meetings, and they have to be in-person meetings with certain rules and regulations on promoting hybrid type meetings. But at this point, I've contacted the assistant director of the Bureau of EMS to ask him if we can still go to a hybrid or a Zoom meeting, and I have not gotten any response back from him as of yet. There was some guidance that was put out a couple of weeks ago, maybe 2 months ago, and we followed that for the last 2 meetings, but it required some people to be in person in the office. So I'm not sure Zoom is an option that we can use on a regular basis unless that public meeting law changes, which is Executive Order 07, I believe. Came out a while back from one of our governors.
But he's gone, so all that stuff is to the wayside, right?
No, that's not true. This goes back even before him.
Oh, really? I
Yes.
thought, because all of his executive orders get suspended, right? April 1st or something, whatever that was, whatever that date was.
Right, those were for special meetings where we could go strictly Zoom. Now, they changed one of them that says that we could do hybrid, and I'm still not sure that that's in effect, because I thought that left with the governor. So that's why I'm trying to get in touch with Steve DeZura to find out if it is or is not. I was just looking to see, I thought,
My favorite guy, he was just so informative when we talked about our upgrade policy. So, yeah, so let us know, but for now, let's keep it Zoom until, something else comes down and edict come down, because I think this is easier for everybody. We get better attendance. It allows for people to, participate and, to be still able to carry on, because I think we're all really busy. I mean, I think it's pretty tough, and I think we have to try to make it as easy to attend as possible and not make it a forbearance, so I think let's leave it for now as this, unless anybody has any objections, and we'll wait to see what Bill finds out from the executive order.
So Pam, the little bit of research that we were able to do, just to kind of echo what Bill was saying, so you're clear on it, is that you can have hybrid meetings, and it wasn't an executive order, it was an interpretation from the DLA of what could be allowed now, but at least 2 active members of the committee, if it was an official public meeting, had to be in the room, so that if the public showed up, there was at least 2 members there. So you could absolutely go to a Zoom style meeting as long as 2 of your colleagues decides to show up at the regional office, and then it has to be open so that there's both questions and answers from the public to at least 2 people in the meeting. Now, the only other thing that throws into effect is the region didn't have the equipment to do that. We borrowed it, and we made it happen for the last council meeting. So we could, I guess, hunt and peck and try and find the money to, purchase the equipment to make that happen. What I don't want to see you do is go to 100% Zoom and then someone challenge you legally that you held an illegal meeting, and whatever you decided on is now null and void. That's just tidbit.
Yes. So David, is that why you're in the room? Thank you.
Technically, David's not on.
I know.
Yep. Love to be here.
So what we can do is, I understand what you're saying, David Grass, because you don't want any of these things to be challenged. Let me think about that. I mean, I'm the closest to the office, so it definitely makes sense that I would be there. Let me think about that. We'll work on that, but we do want to follow the rules. We do want to follow. So Bill, see what they say, see if you get a word back from my favorite guy there, and we'll go from there. Now,
I'd just like to make a comment. I mean, yeah, I think the solution is just to figure out how to have 2 members of the REMAC present, and, because that's our reading of what the protocol is to make this quote legal. But the other thing I will say is this, that, I don't think we should, and again, this is all pending on what rolls out over the next year with COVID and where we're going with this thing, and how this disease process and this infectious rate and all that kind of stuff sort of rolls out. But I don't think we should go to a thing where we're doing exclusively Zoom meetings. And I think we should probably put in something that we do, 2 out of whatever our 8 in person, or 4 out of our 8 in person, because I think there is, look, and I'm sure everyone here on this call will say that they do enjoy, yes, it's a hassle. Many of us have to drive an hour or 2 hours to get here. But there is, something about all being in the room together and being able to exchange stuff, and just that whole sense that you get from being in the room with people that you don't get from being on these calls. So I don't want to abandon these things altogether because we've entered a new age.
I think also where I see the biggest impact, Eric, is when somebody presents something. It's kind of different when you're in person versus on a Zoom. I get it much more when we're discussing it in person. And, that's where I think it makes a big difference in presentations. Okay, any other comments? So the other issue I think that's pretty on the forefront of all of our minds, and I'm sure affects everyone, is the whole transportation dilemma and getting patients interfacility transports and 911 volume, and just the whole process behind transportation in the pre-hospital arena. It's definitely nationwide. I have a lot of friends in California that are practicing, and down south, some of my residents moved on to other places. And
you got no friends.
I don't know if you guys know Dr. Oxley. He just interrupted me to say I don't have any friends. But he's so funny. So I think that, it's a thing where I don't know if there's creative ways of what we can do. We're trying to work on a solution here at Garnet, but it's really quite serious. And I know in some areas, the 911 call volumes really affected. So any comments, anything anybody's working on, any ideas, anything you think we need to do to try to help this terrible situation?
This is Evan Cohen from St. Luke's. We just mentioned that we've had a few occasions where we had stable psychiatric patients for transfer, and we had security, take the patient with a nurse to the receiving facility. So just trying to get a little creative with really stable patients that can we use an alternative route other than an EMS rig. That doesn't obviously solve the problem, but little bits and pieces help.
In Texas, they use the sheriffs.
Yeah, I would say I would recommend using a legal police or, sheriff, some kind of process that way. Just because a nurse in a car with, I don't know how you guys did that, but
it went through like our legal and hospital administration, but yeah, it is. I'd certainly rather police be present if that's an option.
Yeah,
that might be appropriate for someone who's a voluntary psychiatric admission, or for a detox admission in which they presumably have the capacity to be discharged potentially. That might be perfectly appropriate. I wonder whether there's been any discussion of any public service announcements that, many school children are being transported to school these days by their parents rather than using public busing systems in order to minimize the number of buses and crowding and all of that in this era of COVID. I wonder if public announcements to the public saying, unless you need an ambulance, don't call an ambulance. If you have an emergency but can feel like you could get yourself to the emergency department. Now, obviously that would need to be carefully worded, but consider taking yourself there if that's a reasonable option.
Yeah, it's really difficult. I think we had a case here where the patient needed to go to their center in the city, and literally we couldn't get transportation, and so the family took them. He wasn't in dire straits or any emergent kind of process, but he did need to go. And like in the old days, we never would have let that happen, but we just couldn't get any transportation. So I don't know. It's a tough call. But Dr. Cohen, I think, what I would, from a safety perspective, I know legal, weighed in on your thought process there, but I would definitely use the police or sheriff to do one of those transports. Definitely, I think that's a safer way to go.
Does anyone have experience with, that sort of relationship with their local police departments and, had like openness to the police doing that sort of activity for them?
We occasionally do that for our detox admissions, in which case we have Oracle, part of the police force is involved with the patient already, and they sometimes will transport the patient to a detox facility.
The troopers offered for us for one recently, which I thought was pretty nice of them.
Are they happy getting involved? Probably not, but and a lot of these psych cases also, they're voluntary until they're not voluntary. I don't know if you guys have been experiencing that, but we get psychotic patients who'll they say they're voluntary. Next thing you know, if they want to leave, you have to
they're not
chemically restrain
voluntary
them.
anymore. That's what makes me think that having law enforcement be involved is much safer. I agree.
I agree too.
Yeah. So one of the things, Dr. Cohen, you could talk about there is Orange County Sheriffs, because they definitely do respond to your area. And the troopers, I think, also have been helpful at times, but I don't know, that would be more the avenue I would take, especially with a psych patient, because, they definitely change like the wind sometimes. And then as soon as they get close to the place, they're like, no, I am not going in and not doing anything. So it can become a nightmare. Any other comments? Any other ideas? Anybody's working on anything we think we can help out in as a regional, committee that is responsible for really the welfare and the ability for pre-hospital care in our region to survive? Yes, Israel.
So I had a question too regarding transporting patients. We are called often to the hospital to help them out, take patients to another hospital, take them home, discharge. And we recently had a situation where we had 2 patients in the ER, both of them very stable, both of them going for psych evaluation, extremely stable. I mean, they were there in the hospital for a few days waiting for transport. And we took them both together on one ambulance. And I just wanted to know what the thoughts are.
Wow.
Anyone? I see the DOH is not here, so I felt free to make that comment.
I mean, I think it's more of a safety issue for your providers. Do they, in times of certain, catastrophic events, things like this occur. But in this sense, it's just a run-of-the-mill kind of daily process. However, I understand what you're saying. When they're so stable, they're going to the same destination. Why couldn't we do it with multiple people in one bus? But I don't know legally, how does that work out? I mean, I think that from a legal perspective, are you held to just one?
I mean, the only legal ramifications that I can think of, when we asked the hospital, they went to their legal department, they had no issue with it. The only legal thing I could think of is if we bill both patients, and I'm not sure if that's so ethically okay. But it wasn't a question about billing. We did it for the hospital. I don't think we even checked if they have insurance, so we got pre-authorization before. It was just both patients were in the ED. I mean, one was there for 72 hours, one was there for 96 hours. It was just, we just felt so bad that, the other patients staying there and they don't know when they're gonna go. And they were both pediatrics. They were both very stable. They're just really going for an evaluation to another hospital.
I think
I know you're all medical directors, so I am just wondering if this is like terrible. If you have no comment, then that's fine too.
I think that, in that case, you were really trying to help out both the patient and the institution, the patient who's been sitting there forever. I think one of the places where, a big problem is adolescent and pediatric psychiatry care now. And we've had considerable delays because there's just no availability of beds. And, you know, we tried to reach out. There was one case we had, he was here for 16 days, 16 days. And we reached out to all the state institutions, from Office of Mental Health all the way through, and reported it all the way up. And they really, I have to tell you, he still stayed 3 or 4 days before any solution came down from them. And still, the only reason why it occurred, Israel, is because a place finally saw some compassion to say, okay, let's try to get this kid somewhere. It was impressive, and no one would listen to us. No one wanted to hear that this was happening. They kind of were putting their heads in the sand, to be honest with you.
Israel, this is David. The only thing I can think of that could be problematic would be potential HIPAA issues if the folks haven't agreed to, and there's some information sharing. That might be the only thing I can think of that way.
Oh, they were so thankful that we took them. I mean, they both families were like, oh, please, it's not a problem. I mean, we wouldn't do it otherwise, obviously, but I hear what you're saying. It's a HIPAA issue because you have to ask the patients in the ambulance, so what's going on with you? We kind of did that before. We spoke to the doctors before on the side so that we don't have to go through this whole thing on the 45-minute ride and say, so why are you here? Why are you here? We spoke to the doctor about both patients. We asked for a face sheet, and we just kind of rode along. We had 2 providers in the back, and that was it.
Israel, also, I commend your efforts. Really, this is, we have to be thinking outside of the box, and just something you may want to consider, especially with legal counsel, is maybe there's a separate waiver that you can have that both patients sign with regards to the privacy of the information. That may help you out a little bit. And so,
and the other thing would be just document the whole situation really well. I mean, the fact that these 2 young folks are being held for X amount of time, difficulties in getting transportation for them, sort of the background stuff, and then the case and the transport in depth, so that if anyone ever questioned it, then you have a very, sort of justified, this is what we did in a semi-emergency situation in which these people, to keep them left in this ER for extended period of time was definitely not good for them. And they needed to go to be evaluated at the appropriate institution. And for their own safety, this was kind of, and mental well-being, this is kind of what was done in an agreement with the hospital, la-di-da, but a just, well-written, transfer PCR.
Sorry, it's not unusual, just so the medical directors know, it's not unusual to transport 2 patients when you come to an MVA and you have 2 patients or 3 patients, or sometimes 4 patients. So it's not like totally unusual. It's just unusual to do it outside and not the other way around.
That's a great point.
Absolutely. So ladies and gentlemen, certainly we've been here a long time today, and I think that what is important is that this topic be kept alive, right? We all are dealing with this every single day. I know we as an agency have been working on it extensively for about the last 6 weeks and made some drastic changes to the way we operate here. But I think the biggest challenge that I continue to find is the concern that people are not speaking about this or not raising this to the appropriate people. There are still lots of heads in sands where we believe that this is not a problem. And I think having these discussions is what we need to do, right? So we all need to go to hospital administrators. We all need to go to our state reps. We have involved our regional state chief. We've also involved the director of EMS from the state. And I think you all need to do the same thing. We are only going to get these issues solved by speaking about them. We spoke with every single one of our mutual aid partners around us prior to us taking the steps that we took so that they understood the position that we were in. And I think we certainly have stimulated lots of conversations in our area. One of the conversations actually that I had yesterday with somebody with one of the agencies from Ulster County, and I was pretty surprised he said it, but he says, "Oh, you have a problem in Dutchess as well," and so. So, right, these are things, I mean, we are all having these challenges and they think it's unique to them. So reach out and speak with other folks and let's keep this topic alive. We only are going to address these things by talking about them all the way up to the governor's office.
So this is Dave, and I'd like to echo Mike's point and say that truly from an EMS perspective of this, I know the REMAC doesn't always totally get to see some of the other behind the things happening on the EMS sides, but we've been working on the political side of this, and each county, city, township, political advocate really needs to understand what's happening in their EMS system, because to Mike's point, they don't know, they don't understand it, they don't know how the EMS system works and what's happening and the fallout from it of what's happening. And that's really important to do too. We did a big study in Dutchess County about that a number of years ago. And a majority of the folks from their political constituencies had absolutely no idea the impact of EMS and then the subsequent fallout, which now we're seeing at the hospitals and ultimately, for patients that have to wait any place, not get the right care that they need, not get the right care on the way to the hospital, and then, at the hospital. That really ends up being a problem. And those folks really don't understand or know the process. And I think it's going to get harder before it gets easier. But this is certainly a time for some of the out-of-the-box thinking of how we can address some of these issues, get everybody on the same page and sort of move forward.
And I think that, it's just an interesting comment that somebody says, oh, it's happening over there too, because I don't think people realize the ramifications and how far this extends, because it really is totally nationwide. And it's, something we do need to keep talking about. We need to keep working on and try to help as best we can and be creative like Israel and his team was, because that was a great process that they showed there. And thank you to KJ. Any other comments or concerns, or I'll bring this meeting to conclusion. I appreciate everybody's time today. I appreciate everybody's comments and interactions. It's so important that we all work together on these issues and provide good care. And I'll echo what Dr. Larson said before. If we can make an effort to try to sign up for NDMS or DMAT to help out around the country, it definitely is helpful. I started the process before, but it is laborious, and boy, I just couldn't finish it. So I will try again, Eric, because it was tough the last time. I'm like, what? I thought vetting onto CMAQ was tough. Thank you, everybody. Can I have a motion to adjourn? Yes, and second. Thank you, Dr. Modori. Okay, you guys have a great day, and thank you so much.
Ciao.
Thank you.